To say that we can fix Alzheimer's disease by removing amyloid is not the correct statement. If you have an elevated p-tau217 and you're 40 or 50 years old, that's a huge wake-up call that there's something going on in your body. Anyone who will poo-poo the APOE4 as, this is just an increased risk and there's nothing I can do about it, I can't modify my genes, completely false. And ignorant to the literature, ignorant to what's going on in the rest of the world, and it's malpractice. If you have 2 copies of the APOE4 gene, but let's say 10 to 12 times than the general population, increased risk of late onset Alzheimer's disease. So the habits and the things that we do in our 30s, our 40s, and our 50s, that's going to equate to disease state that we're not going to be happy with in our 60s, 70s, and 80s.
Well, hey, everybody, we're going to get right back to the podcast, but I want to share something with you that is very personal. For decades, I've been a practicing neurologist. I've been asking a single question, and what makes a good brain go bad? More importantly, obviously, what can we do about it? And that question has led me to write my new book, which is called Brain Defenders. It's now available for pre-order. And in this book, I'm going to take a hard look at where we are today and offer up some challenges as to where we are today in terms of what we're being told. Despite all the attention on targeting proteins, misfolded proteins like beta-amyloid for Alzheimer's, we still don't really have any meaningful treatments for diseases like Alzheimer's and Parkinson's disease per se. And we certainly can treat symptoms, but as it relates to treating the underlying issue, we're falling short. Many of these approaches manage the symptoms at best, but without really addressing what's driving the underlying process. And this science is evolving, but what's really exciting is the emerging research on what I've called the microglia. I didn't call it, but that's what they're called. These are the brain's immune cells. And when they're balanced, they are protecting, they are repairing. Well, when they're dysregulated, and we can talk about why that happens, and we do talk about it in the book, they can drive inflammation and lead to brain degeneration, often long before symptoms appear. And here's the empowering part. These microglial cells are deeply influenced by your day-to-day lifestyle choices, your nutrition, your sleep, your environment. And in the new book, Brain Defenders, I share both the science and provide a practical roadmap that'll help you calm inflammation, support supportive microglia, and really ultimately take control of your brain's destiny. And if you pre-order your copy today at braindefenders.com, you can receive some special bonuses like a sneak peek at chapter 1, the full glossary for the book, and curated offers from my favorite brain health products, many of which I've discussed here on the podcast. This is a new way of thinking about brain health, and I truly believe that this book hopefully is going to change everything. I can't wait for you to read it. And I think you're going to be as excited as I am about the information you're about to receive. That said, let's get right back to our podcast. Well, hello, everyone. Dr. David Perlmutter here. Welcome again to the Empowering Neurologist. We're entering a new era in brain health, an era in which we are able to really see Alzheimer's disease long before the actual clinical manifestation, long before things like memory loss begin. For decades, we have waited for symptoms before we took action. And in many regards, this still seems pretty much like the standard of care. Despite an enormous investment, we still lack meaningful therapies that reliably can alter the course of this disease. The story is, however, changing. That's certainly good news. We now have seen quite recently the advancement in what we call biomarkers, imaging techniques, genetics, and even computational tools that are giving us an incredible depth of insight into what is the actual biology or misdirected biology that underlies Alzheimer's disease, sometimes actually years before symptoms, as I mentioned, like memory loss, begin. And this gives us a window of opportunity, if you will, for the development of an informed, personalized prevention type of approach. Now, to help us navigate this rapidly evolving landscape, we're joined by an extraordinary expert in the field, Dr. Jonathan Fellows. He is a neurologist with more than 25 years of clinical experience, which means treating patients. And he also serves as the director of the Alzheimer's Disease and Memory Disorder Center at the Michigan Institute for Neurological Disorders. That's the MIND. He is nationally recognized for his work in early detection, comprehensive diagnostic evaluation, and in guiding families through the very complex and certainly challenging process of understanding the cognitive changes that are taking place in their loved one. His leadership extends to training the next generation of neurologists as an associate program director of the Corewell Health Neurology residency program. And during our conversation, we're going to explore things like, what are these new blood-based biomarkers all about? We've touched upon them on the podcast before, such as looking at things like p-tau and neurofilament light. And what do they tell us? And just as importantly, what don't they tell us? We'll discuss why these tests are groundbreaking, but still only one piece of the diagnostic picture, alongside imaging, things like lumbar puncture, clinical evaluation, of course, most importantly, a deep understanding as to who this patient is. We'll also look at the powerful role of things like lifestyle choices. We've talked about this quite a bit: exercise, nutrition, sleep, reduction of stress, our vascular health, and eliminating harmful exposures, as they represent what we call foundational pillars across our entire lifespan, not just as it relates to our brain. This is especially critical for younger adults who may not realize how much brain reserve is really shaped during midlife. And finally, we're going to talk about what the future holds. Where's neurology headed? What about AI-driven diagnostics, digital biomarkers, genetic risk scoring, which many people are actually availing themselves of, and the emerging science of a personalized brain health score. This is an important and certainly timely discussion, and I'm very delighted to have Dr. Fellows join us today here on the Empowering Neurologist. Let's jump right into our interview. Well, Dr. Fellows, welcome to the Empowering Neurologist. Glad to have you.
David, thank you so much. I'm really excited to be here.
I'd like to start off by calling out the fact that, what you do isn't necessarily what all neurologists do. I mean, in neurology school, we didn't learn about things like prevention, about lifestyle choices. So how did this enter your life?
I credit, honestly, quite frankly, people like you and others, your colleagues, in terms of that. So myself, like everybody else that started neurology residency, we did what we were taught: evidence-based medicine, drug. And then you realize along the way that pharmaceuticals are one part of the picture. Okay. We know that we can empower ourselves by taking control of our lifestyle, modulating what we do on a day-to-day basis that has not small, but actually really meaningful impacts on our health, on our life, on our longevity. And the same applies to really all degenerative diseases of the brain, all neurodegenerative diseases.
So you've recognized that there's more to the story than what we learned. And, to be fair, what we continue to learn, at least if we just remain focused on what's published. But, there's a lot being published that's dealing with lifestyle these days. And we really want to spend some time with that. And I think that's going to really lead us to the understanding that, there's a huge role to play in terms of understanding our metabolic health, in terms of some of the deep mechanisms underlying brain degeneration. I think our focus today is going to be Alzheimer's. Let's talk first more about the institute where you work, the Michigan Institute for Neurological Disorders. How does it come to be that there is an institution like this that is really embracing, this very forward-thinking approach to brain degeneration?
So we're the largest private practice neurology group in the state of Michigan. We're a suburb of Detroit, southeastern Michigan. We are affiliated with a few of the different hospital systems around in the area. We actually are program directors of the largest residency program in the area as well. Obviously, there's University of Michigan, there's Detroit Medical Center, and we're part of Corewell Health, and we're the residency program directors as well. So we wear a lot of hats. We have 4 different offices. I'm in our main office in Farmington Hills, Michigan. And I guess it probably started in the days of multiple sclerosis. And there's a lot of correlates in terms of early MS, disease-modifying therapies, and where we're at right now in terms of Alzheimer's disease. So, but we also realized way back when, in the 90s, that really the drugs are only one part of the picture. And my mentor was a very big proponent of lifestyle modification, even before it was
Nice.
kind of like popular and sexy to talk about those things. And there, but I'll be honest, David, it's daunting. There's so much information out there. It's hard enough as a general neurologist, let alone like a memory care specialist, to keep up with the evidence-based medicine and the data revolving around pharmaceuticals, and then to throw in all the lifestyle and sort of marry that so we can really, take the best care of our patients that we can. I mean, hey, we're in business. We care for patients. That's what we do for a living. We're clinical neurologists.
I get it. Believe me, I get it. It is very compelling. But I have to tell you an interesting story. Hadn't planned on this, but I interviewed somebody yesterday who's a fertility specialist. In fact, I think I have her book right here called Trying, and it's about what's her interaction with couples that are having difficulty with pregnancy. And incredibly, she looked upon the ability to become pregnant for conception based upon the metabolic health of the mother, secondarily the father, but the metabolic health. And she said, that must sound, kind of strange to you. And then she realized, actually what's going on in your work in Alzheimer's as well. So with that as a prelude, what we earlier talked about, you're meeting now with a family that mom, dad, or spouse has just been diagnosed with Alzheimer's disease. They ask you, well, what in the heck's going on? What is Alzheimer's disease? Where do you begin that conversation?
Yeah, I mean, the conversation started even before then. So basically, we're getting the history of from the patient. And, the keys are not just memory loss. It's really, we talk about the patient. It's really important to zone in on like praxis or difficulty in doing some previously learned tasks. So to me, that's a really important factor in terms of diagnosing, degenerative disease of the brain, in particular, most commonly Alzheimer's disease. So everybody walks into a room, forgets what they went there for. Am I concerned about that? I'm concerned if it's repeated and it's a big change from what they've done before, but I'm more concerned when they're having trouble with driving, trouble with doing a recipe, trouble with ADLs, activities of daily living, and things like that. So those are the initial steps we're taking with an individual and a family in terms of diagnosing that disorder. Now we go along with imaging studies of the brain, blood tests to exclude other metabolic causes that can be associated with, encephalopathy or memory problems, things like that. The usual thing that any neurologist will do. And then we're going to go on to any sort of like biomarker analysis. So are we doing a blood-based biomarker? Are we doing an amyloid PET scan? We have to have some sort of biomarker proof that there's amyloid in the brain. So amyloid in the brain by itself is not enough. Amyloid in the brain plus the right clinical picture, that can equal Alzheimer's disease.
So amyloid in the brain by PET scanning is not enough.
No, because we have to have the correct clinical picture to go along with that. We know for a fact that amyloid deposition starts 10, 20, or even 30 years prior to the onset of clinical symptoms if a patient's going to get Alzheimer's disease. So amyloid just by itself, even that biomarker positivity, does not equal AD.
And clearly, you have countless patients who have relatively low, I'm assuming, low levels of beta amyloid, and yet you feel you're compelled to make a diagnosis of Alzheimer's even when amyloid levels are low at times, correct?
That's correct. And we're big believers in amyloid PET, and we're big believers not just in amyloid PET, but getting a Centiloid level as well. And a Centiloid score for your viewers is basically kind of like a 0 to 100 score, 0 meaning no amyloid whatsoever, a healthy young person, for example. 24 to 25 is sort of the cutoff. That's going to sort of say, okay, yes, now we're starting to see some degree of amyloid, and 100, now we're concerned. That's not to say you can't have levels of 150 or 200 or things like that. There are, I've had a patient with a Centiloid score of 400, so off the chart level of amyloid. And not always, it's really confusing. I'm still having a hard time grasping this. We can have patients with relatively low levels of amyloid in the brain and rather significant disease. We can have patients with off the chart levels of amyloid in the brain, and they're relatively asymptomatic or quite mild disease. So we're still struggling with that in terms of correlation of degree of amyloid. And
Sure. Yeah, but it'd be unlikely that out of a research setting that someone's going to have an amyloid PET scan who's cognitively intact. That said, let's talk about the ability that individuals have now to undergo blood-based biomarkers, even on their own in the absence of interaction with a physician. But let's just take it to the clinical setting, the physician's office, and a patient says, I'd like to have my p-tau looked at, my neurofilament light levels looked at, and why is that a good thing? Is it a bad thing? What's your take on these new blood-based biomarkers?
I think, well, overall, they're amazing. So to be able to just do a blood test and get a great deal of information about your sort of your amyloid metabolic health, I think that's a really wonderful thing to be able to do. So let's talk about p-tau, for example. That's probably the most popular, well-studied. It's even FDA approved if we want to go down that path. But p-tau217 in particular is going to have the highest sensitivity and specificity in terms of evaluating folks for the presence of amyloid. It's probably the most powerful surrogate for beta amyloid in the brain, and we can test it in the blood very easily, whether a doctor orders it, and there's plenty of at-home kits as well where you can get blood draws done, and you can get this done as part of metric analysis with different, combination of blood-based biomarkers, and you can get really good information from that. We're not doing that. We're at the practitioner level. We will draw p-tau 217, for example. The patient for me that I'm going to do that in the sort of the pre-Medicare patient, the younger patient that is experiencing cognitive loss and probably has some degree of family history, because we can't discount that, because family history is a big deal when we talk about the risk of developing Alzheimer's disease. So,
Well, you've talked about changes are happening in the brain long before there is cognitive decline. I mean, I think that's a pretty general assumption that many of us make now. And therefore, would it not be valuable for a younger person who's cognitively intact to know his or her p-tau217?
yeah, I think you make a really good point. I think that at the end of the day, it's hard to argue against that statement. I think my answer would be yes. It's not what I'm doing in clinical practice, but the answer is yes. Again, it's resources. These are not inexpensive tests. And again, you're testing them, you're doing it longitudinally over time. So it's multiple blood tests, and it's not done in isolation, and it's not done in a vacuum, so to speak. So it's done in sort of concert with a big push toward lifestyle maneuvers. If you have an elevated p-tau217 and you're 40 or 50 years old, that's a huge wake-up call that there's something going on in your body that if you're not willing to make that investment in time and energy to fix that metabolic derangement, then you're going to be in big trouble. Again, like the habits and the things that we do in our 30s, our 40s, and our 50s, that's going to equate to disease state that we're not going to be happy with in our 60s, 70s, and 80s.
Hey, everyone, we're going to get right back to the podcast, but I have an important message for you. If you're caring for somebody with Alzheimer's, any other form of dementia, or even what we call mild cognitive impairment, or maybe you've received one of these diagnoses yourself, or if you're focused on preventing cognitive decline, I want to speak directly to you for just a moment about some serious research that's going on looking at what we call 40 hertz light and sound simulation. We've been actually talking about that on the program. Here's the challenge. Not all 40 hertz light devices are the same. Most use what's called stroboscopic light, and that's the type of light that flashes, then you can see the flashing, and that can cause nausea, it can cause headaches, and if you can't tolerate that, you won't use it. So there is a company called Optoceutics. They've solved this problem with a patented technology that still gives you the 40 hertz light flashing, but through light that looks and feels quite normal. It's the device I actually have on my desk when I'm working, and that's why this company sees a 94% adherence rate and significant improvements across various metrics, including mood, energy, focus, sleep, and memory. And the light is called the EV light, EVY. You can use it, as I do, when you're working on your computer, when you're reading, when you're watching TV, eating breakfast, whatever. It becomes really part of your day, not just another burden. It's kind of passive in the background. So I recommend giving it a try for 90 days. And if you and your family don't see value in it, then you can return the device for a full refund. They cover the shipping both ways. And you can learn more about Optoceutics at optoceutics.com/Perlmutter. You can use the code to get $200 savings. The code is Perlmutter, my last name, 26. This is a device that really is risk-free in terms of getting involved with 40 hertz stimulation. Important information. Let's get right back to our podcast. I'm in your office. I'm 47 years old. Don't I wish? I'm 47 years old, and I've been to another doctor. I did something online. And I come in with an elevated p-tau217. What are you going to tell me?
Well, first, for that individual, I'm going to do the rest of the workup first. I'm going to get the whole slew of other blood tests to make sure there's no significant metabolic derangement. Work closely with their internal medicine primary care physician to make sure that they've done a good job at controlling hypertension, diabetes, things like that, and metabolic derangement. We're going to do some sort of cognitive testing. At that point, at that age, it's unlikely that things like a MoCA or MMSE are going to be of really any great value. So I'll probably do some sort of more formal in-depth neuropsychometric testing. We'll use our neuropsychology colleagues and lean on them for some additional testing to sort of tease out what kind of memory problems are going on. We're going to do a anatomic picture of the brain. We're going to do an MRI scan of the brain with susceptibility imaging to make sure we don't see any. Again, they have an elevated p-tau 217 blood-based biomarker, good surrogate for amyloid. Amyloid can cause hemorrhage in the brain. We want to make sure that there's no evidence of microhemorrhages or anything structural going on. Is there evidence of atrophy? Is there evidence of white matter changes or microvascular disease? Is there evidence of prior stroke that was silent and we didn't know about? So there's a lot we can glean from just those simple tests, get back the neuropsych testing, things like that. And then, are we actually dealing with a very early onset, not a late onset, but an early onset of Alzheimer's disease? Or are we just dealing with preclinical Alzheimer's, preclinical amyloid in the brain? And then we're going to have a discussion about lifestyle maneuvers.
Well, the first thing you mentioned then with respect to being confronted by that patient is you're going to talk to his internist or her internist, and obviously the patient as well, about metabolic issues. And you mentioned things like blood pressure and blood sugar. Because, I think that it's quite clear that insulin resistance and elevated blood sugar does set the stage for much of the downstream issues that lead to brain degeneration and even amyloid accumulation. So doesn't it then make sense for people like you, and you're doing this, to really get the message out that we've got to maintain and improve our metabolic health in our 30s and 40s if we don't want to end up in our mid 60s and 70s and then having really positive changes on the various studies that you're talking about?
There's no question. And I think the momentum's there. Like, again,
Mm.
between like work that you do, Mark Hyman, Dale Bredesen, if you start, these guys are your message is being propagated on social media. So it's not like you don't have to like look far to try and find it now. It's out there. This isn't, 10 years ago, you had to dig for it. It's more prominent. And the fact that there's data behind what you guys are doing, I think leads to the motivation of physicians, maybe in their 50s now, that didn't learn this in residency. No mentor taught them that when they were training. So this is sort of like an evolution of an individual, like sort of in their 40s or 50s in practice, that they can then go on and help some of their patients with some of those same things.
So let's take it to the next step then. You've done the very best you can with a person who is, in fact, demonstrating some cognitive issues on cognitive examination, has elevated amyloid seen on the amyloid PET scan, elevated p-tau 217, et cetera. And you've really engaged that individual in a pretty darn good comprehensive program of metabolic rejuvenation, getting the blood sugar down, getting blood pressure under control, getting that patient to exercise, looking at sleep metrics, quality, quantity, et cetera. When do you start thinking that this is a candidate for medication dealing, specifically targeting beta amyloid?
Yeah, it's a really good question. And not everybody is a candidate for anti-amyloid therapy. Let's get that very clear. That's number one. So say, for example, you have a patient that you just described, amyloid positive based on amyloid PET scan, and their hemoglobin A1C is 11, their blood pressure's in the 160s, they're obese. I'm not putting that drug, and I'm not putting that patient on anti-amyloid drug. Okay, we're just fighting against too many other variables. So again, to say that we can fix Alzheimer's disease by removing amyloid is not the correct statement. Now, is there data to say that we can slow disease progression? Yes. I mean, we know that that's there. Is it amazing? No. I tell my patients, listen, where we're at right now with anti-amyloid therapy, it's good, not great. And we talked about MS before. We're in Alzheimer's disease, when we talk about drug-based pharmaceuticals, infusion-based therapies, anti-amyloid drugs, we're where we were in the 90s with MS, with the ABC drugs, Avonex, Betaseron, Copaxone. And the data is kind of similar in that regard, 20, 25, 30% reduction in relapses. Well, now if you look at any infusion center or any MS office that has infusion chairs, those chairs are not filled with patients getting IV Solumedrol because of exacerbations. The drugs we have now do a really, really good job at basically shutting down multiple sclerosis. Are we going to be there 20, 30 years from now with Alzheimer's? I guess that remains to be seen. But if we can couple the phenomenon of healthy lifestyle, like you say, making sure sleep is adequately controlled, making sure the patient doesn't have sleep apnea, making sure they're putting reasonably good foods in their mouth, restricting to, I would recommend like a Mediterranean diet to my patients because I think it's really easy to understand. I think that if you talk about diet, when you talk about foods, I think it gets really complicated. We have a finite amount of time to be with the patient. And I think when you can talk about a Mediterranean diet, that really resonates well with them. Something that's very plant forward, more fish, less meat, high omega-3s. Alcohol is sort of this one that I struggle with a lot because you'll see some studies that tell you, oh, you can have 2 to 4 drinks a day, red wine, this, and so quite frankly, I have a hard time with that because I feel that that's probably too much, quite frankly. But
It is, in my opinion.
yeah. So we talk about, diet, and then we can't, the number one would be exercise. And exercise is like a terribly dirty word in the clinic because most of my patients are not, they're not exercising. So again, we're fighting against so many other things. So if we can make small changes in the day-to-day lifestyle of the patient and couple that with pharmacologic therapy in the right patient, we have an opportunity to do some good.
I'm really enjoying this. To be fair, you mentioned some of my colleagues, and you're certainly more mainstream. And to hear you being so supportive of these lifestyle interventions is really refreshing, and I'm enjoying that. What do you tell patients about these blood-based biomarkers? I mean, how do you contextualize them in terms of what they should be reading into them?
Yeah. Well, first of all, it's a tough situation. They read about them, they hear about it in newspapers and television and things like that. Oh, FDA approved. This is FDA approved. Well, that's great.
Right.
The biggest problem is they're not paid for. So they're cash. You have to still they're not covered by insurance. So although it's FDA approved, Medicare is not reimbursing for these tests. So they could be a couple $100s. So again, for the average individual, we have to have that discussion with the patient as well, that not only am I ordering it, but oh, by the way, you're going to get a bill for it too. And although I think it's really meaningful, helpful, and we're going to be able to guide your treatment depending on the results, but it's going to cost you money. Contrast that with, let's say, like an amyloid PET scan, which is thousands of dollars, completely covered by Medicare. So we struggle with that a little bit too. But a blood-based biomarker is a really easy test. Say, for example, p-tau217, really high sensitivity, really high specificity. So a solid test that's going to be highly accurate, that correlates really, really well with amyloid PET scan, quote unquote, the gold standard to look for amyloid in the brain. So that would be a test that we would order, not infrequent. There's not a day that goes by that I don't order a p-tau217 on a patient.
Well, you've been a proponent of the idea of early detection, and why does that float your boat? I mean, what because that's not really standard of care. If you look around the country, generally, when do patients begin to think that they need to see first their internist and then ultimately a neurologist? Is when they're really already having significant cognitive issues. So you emphasize early detection. And I think, to be fair, I think you emphasize pre-symptomatic detection based on what we're now talking about, these metabolic markers and certainly these brain-related, Alzheimer's-related biomarkers. So why emphasize it? What's the real traction point here in terms of emphasizing early detection?
Right. First, pre-symptomatic, obviously, these folks are not candidates for anti-amyloid therapy. So that's number one. So let's just eliminate that. That's going to be pure lifestyle modification.
Can I just interrupt you for a moment? Yeah. Do you believe there'll be a trend, though? There's a real push to consider Alzheimer's disease being caused by amyloid. The clinical outcomes of patients on anti-amyloid therapy have not been stellar. We would all agree to that. And then the FDA approval came when they said, well, let's not look at clinical outcomes. Let's look at offloading beta amyloid load as the goal, and therefore we approve the drugs. That said, do you think there will be a push to extend the use of these amyloid-based therapies to patients who are not really quite symptomatic?
Well, it's happening now. There's clinical trials right now with anti-amyloid drugs in the pre-symptomatic patients. So that remains to be seen. Really tough trials to do because obviously you're following, and there's so many other variables, and you're following them over time. Like, when does the switch go on that you've now developed, clinically definite, Alzheimer's disease? So the answer is yes. That's being studied right now. I don't know what that answer is going to be. We know for a fact, though, with multiple studies, that lifestyle modification can delay the onset of Alzheimer's disease and slow the progression of Alzheimer's disease. So those things we know for a fact. So those shouldn't be ignored. Now, a patient that has early symptomatic Alzheimer disease, what they call mild cognitive impairment secondary to AD or mild AD. And you can use that as sort of a gauge based on your MMSE or your MoCA score and things like that.
These are studies, these are tests of cognitive performance for our viewers. Go ahead.
Yeah, that are take 5 minutes, 7 minutes to do right at the bedside. Super easy to do. Even a medical assistant can be trained to administer the test at the bedside. They're very easy to do. I want to give you a quick story right now. I had a patient today, literally, I'm in the clinic seeing patients, quote unquote, second opinion for Alzheimer's disease. Patient is 75 years old, African-American gentleman, hypertension, diabetes, hyperlipidemia, reasonably well controlled, not a metabolic mess, could do better, but not awful by any means. Amyloid PET scan abnormal, no Centiloid score, so I don't know how much amyloid is there. So an older school amyloid PET scan, no blood-based biomarker, again, which is fine. Scores a 21 out of 30 on his MMSE. So it's right on the border between mild and moderate. Technically, he's in the mild umbrella. The doctor that saw him previously 3 months ago wanted to put him on one of the anti-amyloid drugs. They came to me and they're like, what do you want to do? I'm like, well, we're not doing anything. We're not doing there's no drug that's going to help you at this stage, because what we know is that the lower your score on these bedside cognitive tests, I can say anecdotally, and we can also say based on data that you are not going to do as well in terms of slowing the disease of progression. Now, the flip side to that is if we have a patient on the complete opposite side, there's data to support that if you have a 27 or above with one of the anti-amyloid drugs, that your slowing of cognition isn't just in the 20 to 30% range that you would look at all players in terms of the clinical trials for the anti-amyloid drugs, but you're actually at a 60% slowing of cognitive decline. Again, is it amazing? It's very good. It's again, one more piece of the pie that we can use to be able to treat our patients to slow cognition. Because remember, it's not just about the patient. This is a horrific disease that affects the caregiver as well. So if we can keep the patient in the mild stage as long as possible, better for the patient, better for their caregivers.
It's really so refreshing to hear you describe this really comprehensive approach, looking at all these variables and all these levers that can be pulled, as it bears on that patient that you saw today. One of the things that you and I are often asked about has to do with genetics. And let's specifically talk about APOE for just a moment. How does that all factor into your decision-making process? And maybe we'll back up a little bit before we get there. Talk about what it is and how it relates to Alzheimer's risk.
Right. So the APOE is a gene that encodes for a protein called the apolipoprotein E. And that's a protein that's important for cholesterol, lipid metabolism in the brain and things like that. So it's a really important, protein, if you will. But there are 3 different forms of the APOE, and they're not variants, if you will, because they're all naturally occurring, and we get one copy from our mom and one copy from our dad. And there's APOE 2, 3, and 4. So with these 3 different genes, we get 6 different possibilities of genotype: 2, 3, 4, 2, 3, 4, 2, 4. So there's 6 different, right? I know. I was thinking about this earlier. I got to make sure I get it right.
You're cognitively intact. Keep going.
Well, we can talk about my APOE if the viewers are interested, because it's one of the good things in life I have going for me. But I'll share that with you after if it comes up. But
I'm a 3-3.
I'm a 2-2.
Wow,
yeah.
You're quite the guy.
LP little a also, so I struggle with that. I often say I'd rather get rid of my LP little a and give me an APOE 4. If I could have chosen, I would have chosen that.
I'd go with a 3, but not yeah.
Well, but you can't have everything. I was being
yeah. But I think you've got good news for APOE 4. I'm sure in the next couple of minutes. But let me not interrupt. Go ahead.
No, thank you. So again, APOE. So on that note, when you said, Superman, APOE 2 is protective against the development of Alzheimer's disease. Interesting, though, if you're homozygous E2, there's a phenomenon of hyperlipoproteinemia type 3. You're actually at an increased risk for that, from a lipid standpoint and a cardiovascular and even cerebrovascular disease standpoint. So you're not completely bulletproof with 2-2. 3 is the most common isoform of APOE, and that's also the neutral form, neither an increased risk nor protective. APOE 4 is the one that people get scared about. That's the quote unquote bad one. But bad is on a continuum, if you will. So if you have one copy of the APOE4 gene, you're at about a 3-time increased risk compared to the general population of developing late onset Alzheimer's disease. If you have 2 copies of the APOE4 gene, again, the literature is a little bit sketchy on this. Back, if you read it 10 years ago, it could be as high as 30 times. I don't think it's that high. It's about 10 to 12 times, sometimes 20, depending what you read. But let's say 10 to 12 times than the general population increased risk of late onset Alzheimer's disease. So it's real. So again, knowing your APOE, I think, is a really important thing. And also, if you're homozygous E4, you're also at risk for other things too, like increased cardiovascular disease, increased cerebrovascular disease. So it's not just Alzheimer's disease that you're a higher risk for. So knowing your APOE status, I think, is probably the number one thing that we can do to set up that foundation that, okay, this is a wake-up call that we need to increase our exercise. We need to put better foods in our mouth. We need to focus on our sleep. We need to make sure we don't have hearing loss. Like a lot of these different things that everybody talks about, but they actually matter when you have an APOE4, even more so than if you don't.
Hey, we're going to get right back to the podcast, but I do have an important message. For decades, we've been told that our genes are basically our destiny as it relates to health, and that everything's locked in place, predicting even our future brain health. But let's be clear, your DNA isn't a verdict, it's a roadmap. And I'm talking to you today about 3X4 Genetics. I actually described them in the new book, Brain Defenders. And this is a company that helps you understand your genetics, what you've inherited, and I think more importantly, how your daily choices can influence how those genes are actually expressed. In other words, how you can control your own genetic expression. And, that matters for your health, and it really matters for brain health, including things like memory and mood and cognitive resilience. You may carry genetic markers associated with cognitive decline, like, as we've talked about, APOE4, but possession doesn't equal expression. Your lifestyle, your nutrition, and metabolic health, all the things that we talk about here on the podcast, can powerfully influence which genes are turned on and which stay quiet. The 3X4 genetics test looks at how your genes impact brain function at a cellular level, and which then, through the 3X4 health journey, which they provide you, guides you through a clear and a science-backed program focused on inflammation, methylation, oxidation, oxidative stress, things that we routinely discuss here on the podcast that are the key drivers of basically what makes a good brain go bad. And we have spoken with the team at 3X4 Genetics, and they were able to get a special offer for our podcast community. So head on over to 3x4genetics.com/Dr. Perlmutter and get that special offer and start really your personalized brain health journey today. Let's get your genes working for you, and let's get back to the podcast. So the point is, though, we're seeing plenty of literature these days indicating that APOE4 predisposition, if you will, for Alzheimer's can be offset by making the very lifestyle modifications that you recommend,
100%.
especially exercise. Exercise has a pretty dramatic ability to reduce risk that would otherwise have been significantly elevated in APOE4 carriers.
There's no denying that. And anyone who will poo-poo the APOE4 as this is just an increased risk and there's nothing I can do about it, I can't modify my genes, completely false. And ignorant to the literature, ignorant to what's going on in the rest of the world. And it's malpractice, basically, if a physician is counseling their patients that this is, sort of deterministic, that you're going to get this disease because you have an APOE4 allele. In fact, it's the opposite. It's not deterministic. Unlike the less than 1% of all cases of Alzheimer's disease of the autosomal dominant forms, like Presenilin 1, Presenilin 2, amyloid precursor protein. We talk about
CP33.
Yeah, you talk about
TREM2.
Down syndrome patients, for example, trisomy 21. Well, the amyloid precursor protein lives on that same chromosome. That's why you're taught in medical school that if you live long enough, if a Down syndrome, a trisomy 21 patient lives long enough, or individual lives long enough, he or she will develop Alzheimer's disease. It's because of that deterministic autosomal dominant gene. That's not APOE4.
So the important thing for viewers to grasp is that you get your genes done by any number of companies now, and variably between 25 to 28% of them are going to show one or two APOE4 alleles. That said, there's positive news here for these individuals that they can take steps to dramatically offset what might be otherwise increased risk. Now, let's just touch on briefly the idea of restricting the use of anti-amyloid therapy based on the genotype, APO, as it relates to APOE.
Right. So actually in Europe, in Canada, if you're APOE4 homozygous, if you're 4/4, you are restricted from using anti-amyloid medications in that genotype population. And the reason why is because of, well, there's a lot of reasons, but I guess the first reason is because of risk. We don't want to harm our patients. So there's the phenomenon, what's called ARIA. ARIA, ARIA, is an acronym that stands for amyloid related imaging abnormalities. And ARIA actually is not a new phenomenon. ARIA, the way I tell colleagues and things like that, ARIA is like a fancier a cerebral amyloid angiopathy, even, because patients who have amyloid in the brain are at risk for bleeding. And the one common way that we would know it as neurologists would be that cerebral amyloid angiopathy, or like multiple lobar hemorrhages over time, hemorrhagic strokes, and things like that. So let's put that aside for just a moment and realize that the ARIA risk, and well, let me back up. ARIA comes in two flavors: amyloid-related imaging abnormalities. It comes in the E form, which stands for edema, or also effusion, or basically swelling of the brain, and also H, which is hemorrhage. And hemorrhage comes in three different shapes: microhemorrhages, little tiny punctate areas of hemorrhage; macrohemorrhage, greater than 1 centimeter in size; or what's called superficial siderosis, which is sort of like cortical bleeding on the brain and things like that. So again, not without risks. And these risks of ARIA increase if you have 0, 1, or 2 of the APOE4 alleles.
Well, what about though with medication, with anti-amyloid medication?
Oh, that's what I mean. Yes, in the presence. Yes, that's what I was referring to. Thank you. So if you're giving,
so that's it. Where do we go? I think we've covered this. We talked about the minimal effectiveness and the potential risk, but what else can be targeted if we don't target amyloid? I mean, where are we on looking at phosphorylated tau as a target, or other types of? In other words, what are you seeing in the pipeline that gives you that you're encouraged by?
Right, I'm encouraged by. Well, first of all, so I partially agree with your statement about the minimal effectiveness of the drug. So I partially agree with that, respectfully. And the reason why I say that is because I do still believe that the anti-amyloid drugs in the right patient have a role. That's number
In conjunction with?
100%, in conjunction
Okay,
with strict lifestyle maneuvers.
Yes.
And again, the lifestyle maneuvers are even more important in our younger years to prevent the problem in the first place. That's the message that really has to be, continued and amplified across for all of our practitioners and patients. But okay, I'm 75 years old. I have amyloid in the brain. I have cognitive dysfunction. I forgot how to drive. I forgot how to do things. I need treatment. So I want to do as much as I can to slow progression. Slowing progression could be the lifestyle maneuvers. Slowing progression could be an anti-amyloid treatment. What else is in the pipe? It's not going to be just one thing. It's going to be a cocktail of medications, whether it's a combination anti-amyloid, anti-tau, other anti-inflammatory cocktails that we can come up with that are going to help patients with this basically neurovascular inflammatory disease of the brain.
Inflammation being a key word there. What sorts of clinical trials are you guys engaged in right now?
We haven't done a lot in the Alzheimer's space. With the Aduhelm drug, we were involved with the follow-up study that the FDA mandated Biogen to do. We were partners in that. We're part of a Trailblazer trial looking at just data extraction in terms of patients that we have right now for really patients that are currently receiving drug. But in terms of new clinical trials, we are currently not enrolling anybody.
There's been a lot of interest this year. In fact, I was reading a Science magazine or Science Technology magazine put the idea of programmable microglia as one of the greatest advances of 2025. Here we are with this interview at the end of 2025. So looking at immune cells, the brain's microglial cells, the brain's innate immune system, how does that play a role in the degeneration that we see in Alzheimer's and Parkinson's?
Yeah, well, it's huge. I mean, again, so you're talking about like beta amyloid or tau being, sort of the diagnostic criteria for Alzheimer's disease. Those are results of neuroinflammation and an immune-mediated reaction that's caused by the inflammation that is yielding this, disarray of our network of neurons and nerve cells and supporting cells and everything like that causes brain atrophy, white matter changes, excessive cerebrospinal fluid, like a million different things going on at once that lead to cognitive dysfunction, cognitive loss. So again, this is where it's an opportunity for me and the rest of the rest of the listeners to learn from you in terms of microglia and what do you call it? Like good cop, bad cop. What is it? That's your term?
Good twin, bad twin.
Yeah.
I was using that in a lecture, good twin, bad twin. I actually had a good twin and bad twin that I made on ChatGPT. And I was going to ask the audience, how many have heard of these twins? Because I named them. I said, don't raise your hand because I made it up. I didn't want to embarrass anybody. But yeah, I mean, I think for me, it's a nice framework because it helps me understand then why are metabolic issues so consequential, because they affect the brain's immune system. And clearly, when we shift these microglial cells from being friend to being foe, they're less able to phagocytize beta amyloid to deal with then the downstream effects of phosphorylated tau and enhance the actual inflammation that surrounds the beta amyloid in the first place. Dr. Rudolph Tanzi at Harvard has talked about beta amyloid. I don't know why I'm focusing on it just a moment because it's an interesting part of the conversation, saying that it is a microbial directed kind of peptide, an antimicrobial peptide, and that in some ways, the accumulation of beta amyloid might be doing the brain some good. How do you deal with that kind of a conceptualization? I mean, we're always looking at beta amyloid as being the enemy. We've got to target it, got to rid the brain. And yet, some people are saying that it's there as a response element. How do you rationalize that?
I have a hard time unpacking that statement. I mean, the only way that I know of beta amyloid is really, in terms of the conversion from the insoluble form or soluble forms into the insoluble form of beta amyloid and then causing plaque. I don't know how amyloid in the brain can be a good thing.
Understood. What's the upside? The relationship then between metabolism and what's going on in the brain. I think there's been a lot of focus on insulin resistance, and we do know that these fluorodeoxyglucose PET scans, for example, or metabolic scans of the brain that show how well the neurons are using blood sugar, are demonstrating changes as much as 2 to 3 decades prior to the clinical manifestations of failing memory, forgetting the Wi-Fi code, grandchildren's names, you name it. I mean, isn't this a huge call for us to really recognize that, gosh, fundamental here is blood sugar regulation?
It's huge. Again, and I mean, the statistics in terms of insulin resistance, hyperglycemia, type 2 diabetes, as in our adolescents, let alone our adult population, is like off the charts staggering. We're doing an absolute terrible job of caring for our individuals in this country on solely the basis of highly processed foods and sugar. So there was a good story my wife had shared with me of a friend of hers that was a preschool teacher. And my wife who's very into longevity, health. She's a physician assistant by training, has done a lot of functional medicine training and plant-based nutrition. And her goal is to keep me alive as long as possible. So she's the smart one of the two of us. So
I know that feeling.
Yeah.
Go ahead.
So she was telling a story of this little kid in nursery school because she was subbing with her friend, and she's showing up, and little kid brings out his lunchbox. And the day before, my wife told her, "Oh, you got to bring the rainbow into your lunchbox," meaning like fruits and vegetables, everything with color and things like that. And he's like, "Look, I brought the rainbow." "Okay, what did you bring?"
Fruit Loop.
"I have Cheez-Its, I have Skittles, I have fruit roll-up. Look at all these beautiful colors I have."
Well, it's a huge issue. I mean, I think that the increased risk of developing Alzheimer's is multiplied threefold in type 2 diabetics. And, another worrisome stat for me is that a third of Americans are pre-diabetic. And the scary part of it is that 90% don't know it. So I think it's really a huge public health issue as it relates to what you and I do. And that is, here is a very powerful modifiable risk factor that people need to know about. And I think that, for so long, people have had their annual fasting blood sugar and, leave it at that. Well, my A1Cs, it seems to be creeping up, but it's below the magic number of 7. That's nowhere near good enough. That's for sure. But anyhow, I want to commend you for the work that you're doing, because you're really putting an imprimatur of good science and research and validation behind, as you mentioned, what many of us have been talking about for an awful long time. So, the Michigan Institute for Neurologic Disease, or Disorders rather, doing an incredible job. And again, I want to thank you for your time today, and again commend you for all that you're doing.
This was great. Thank you so much. I've learned a lot from reading your articles, your blog posts, and links that you have with some of your colleagues. So again, it's this marriage between stuff that we're doing on the front lines in terms of taking care of patients and navigating what drugs are actually worthwhile, what drugs aren't, and the research that you guys do in terms of stuff that matters, decades before to prevent disease from happening in the first place.
Preventive neurology. Wouldn't that be great if there was a board certification for that?
Maybe.
Maybe a while.
Maybe.
All the best, Jonathan Fellows. Great to see you.
Thank you, David. I appreciate the time.
Well, this was a very enriching and clarifying conversation, wasn't it, with Dr. Jonathan Fellows. He's a remarkable individual with a really amazing ability to take this incredibly complex information that's changing so quickly and make it actionable for all of us, for all of us who have to make real decisions about our own brain health and certainly the brain health of our loved ones. As we heard today, we are entering an unprecedented moment, finally, in neurology. We have these wonderful blood-based biomarkers such as p-tau. We talked about that, neurofilament light. And these are transforming the sense that we have underlying these invisible brain changes into finally measurable data. It's accessible, it's scalable, and it's incredibly informative when we apply the clinical application of these tests. Yet, as Dr. Fellows emphasized, these tools are not diagnostic in isolation. That's fundamentally important. They work best when we use these tools in an integrated fashion, looking at things like MRI, PET imaging, and certainly the patient, him or herself, in terms of their cognitive function. Yes, lumbar puncture can be appropriate as well, looking at the spinal fluid, but certainly the clinical examination is fundamentally important as well. And I think, as Dr. Fellows emphasized, a careful understanding as to who this patient is and looking at the whole notion of personalized medicine as it relates to that individual patient. We also explored the central roles of the microglia of inflammation, metabolism, vascular health, much of which we have control over, things like sleep and stress and environmental exposures. That's been a constant theme on this program. In this case, how they shape our cognitive outcomes. This new multi-factor model of Alzheimer's is helping us move beyond this notion of a single pathway view of the disease and towards, as mentioned, a more personalized prevention-focused approach. And for younger people today, these insights serve as an essential reminder that brain aging begins long before we experience symptoms of cognitive decline. Exercise, diet, sleep quality, hearing health, and avoiding certain medications we call anticholinergics that we talked about today. All of these are levers that meaningfully influence our risk and our ability to reduce that risk. I want to extend my gratitude to Dr. Fellows for sharing his expertise and for really the extraordinary work he and the entire team at Mind are doing, including their involvement in clinical trials and their careful, patient-centered approach to evaluating emerging therapies, like we see, like drugs that have been approved. But beyond drugs, what's so encouraging about the approach taken at Mind is that they're looking at the big picture. So if you found today's discussion helpful, please share it with others and stay connected with us here at the Empowering Neurologist as we continue to do the deep dive into the science that allows us truly to take control over our brain's destiny. Until next time, I'm Dr. David Perlmutter here on the Empowering Neurologist. Stay well, stay curious, and hope to see you all soon. Bye for now.